Myself, Dr. Pradeep Kumar Bansal, Assistant Professor of Cardiology in UNMICRC Institute of Cardiology and Research Center, Ahmedabad. Today, we will discuss about recent guidelines for coronary artery revascularization, which I will adapt from the 2021 ACC guideline of coronary artery revascularization. So, outline of my topic is introduction, shared decision making and informed consent, how to heart team approach, define the lesion severity, and how to revascularization in STEMI and STEMI stable ischemic heart disease, and when we decide to PCI versus CABG in patient with complex disease, and revascularization in special population situation. So, revascularization of patient with coronary artery disease has progressed exponentially since Andreas Gunzig performed first balloon angioplasty in 1977. There is greater need to tailor revascularization appropriately, taking into consideration of patient comorbidities, coronary anatomy, personal preferences, and individual perception of risk. So, in this guideline, they have more focus about the shared decision making. So, there is in patient with undergoing revascularization, decisions should be patient centered. That is consideration of the patient preferences and goals, culture, belief, health literacy, social determinants of health, and made in collaboration with the patient support system. And in patient undergoing coronary angiography or revascularization, adequate information about benefit, risk, therapeutic consequences, and potential alternative in the performance of percutaneous and surgical myocardial revascularization should be given, and when feasible with sufficient time for informed decision making to improve clinical outcomes. So, more and more involvement of patient and his and her relatives. Next is more focus about the heart team approach. So, what is heart team approach? In patient for whom the optimal treatment strategy is unclear, a heart team approach that includes representative from interventional cardiology, cardiac surgery, and clinical cardiology is recommended to improve the patient outcomes. The heart team has become an important paradigm in the clinical practice, emphasizing the importance of team consensus on the optimal approach to revascularization. So, like daily to weekly scheduled meetings, remote conferences, and in emergency situation, there should be rapid activation of the heart team. So, what factors should be consideration by the heart team? Like coronary anatomy, like left main disease, multivessel disease, complex anatomy disease, comorbidity of patient like diabetic, systolic dysfunction, coagulopathy, valvular heart disease, malignancy, liver disease, prior CVA, and procedure factor like local and regional outcome, access site for PCI, surgical risk, PCI risk. Some patient factor like unstable presentation or shock, patient preferences, inability or unwillingness to adhere DAPT, religious beliefs. So, these are the factors should be considered by the heart team. So, ideal situation for heart team consideration include patient with complex coronary disease, comorbid condition that could impact the success of revascularization strategy, and other clinical or social situation that may impact outcomes. So, first is how to define the lesion severity. So, in coronary angiography, significant stenosis is defined as a more than 70% of non-left main and more than 50% of left main. Like intermediate stenosis of 40 to 69% generally warrant additional investigation, and there is no standard cutoff for lesion length used to classify severe stenosis. And for there is a coronary where is an indication of coronary physiology study in patient with angina or angina equivalent, undocumented ischemia, and angiographically intermediate stenosis. The use of FFR or IFR is recommended to guide the decision to proceed with PCI, the class 1 indication. If there is a stable patient with FFR of more than 0.8 and IFR of more than 8.9, there is a PCI should not be performed. And for IVUS, there is a class 2A indication in patient with intermediate stenosis of left main is reasonable to help to define lesion severity. And there is a class 2B indication of syntax score in patient with multivessel CAD for assessment of CAD complexity, such as syntax score may be useful to guide revascularization. So, for intermediate, in the case of indeterminate left main disease, studies have shown the IVUS evaluation with deferral of intervention for a minimum lumen area of more than 6 to 7.5 mm square. And in case of non-left main, more than 4 mm square for deferral of PCI is safe. In FAME trial, PCI for stenosis of more than 50% with an abnormal FFR reduced the risk of the composite endpoint at 1 year as compared to PCI guided by angiography only. And in DIFFER trial, they demonstrate similar rates of MACE in follow-up when PCI for angiographic intermediate lesion and FFR of more than 0.75 was deferred rather than performed at 2 to 5 years of follow-up. So, this is syntax curve. They include multiple factors like dominance, coronary segment, trifurcation, bifurcation, lesion, length. So these are all factors included in syntax score. So how to classify, how to determine the line of revascularization according to syntax score. So guideline recommended revascularization techniques in coronary artery disease for amenable patient to both strategies. So like left main disease with syntax score of less than 22, the PCI also a class 1 indication and CABG also class 1 indication. For left main was syntax score of 23 to 32, CABG is class 1 indication but PCI also a class 2A indication. But for left main with syntax score of more than 32, there is only CABG is indication, PCI is not recommended. In like 3 vessel disease with syntax score of less than 22, PCI is also recommended, and 3 vessel disease with syntax score of more than 22, there is a PCI is not recommended. But with 2 vessel disease with proximal LED disease, PCI is class 1 indication and CABG also indication. But 2 vessel disease without proximal LED disease, CABG is 2B but PCI class 1 indication. With patient clinical status definition to guide revascularization. So there is a elective, urgent, emergency and salvage according to clinical presentation of the patients. Next is the revascularization of infarct artery in STEMI to improve survival and clinical outcome. So patient presented with STEMI, PCI is recommended if ischemic symptom is less than 12 hours, failed reperfusion after defibrillatory therapy, cardiogenic shock or hemodynamic instability. And also there is a 2 indication if fibrinolytic with angiography after within 3 to 24 hours, and stable patient within presentation of 12 to 24 hours after the symptom, and if there is an ongoing ischemia, acute severe heart failure or life-threatening arrhythmia, so there is also PCI is recommended. But in asymptomatic stable STEMI with total occlusion of more than 24 hours after, PCI is not recommended. And on the presentation STEMI, CABG is recommended if there is a mechanical complication like VSR, mitral valve insufficiency and free wall rupture. If PCI is not feasible or successful with a large area of myocardium, then also is CABG recommended. But in patient with STEMI, emergency CABG should not be performed after the failed primary PCI in absence of ischemia or large area of myocardium at risk. If surgical revascularization is not feasible because of a no reflow state or poor distal targets. So multiple RCTs or meta-analysis have shown the primary PCI reduces the death, MI, stroke and major bleeding. And also in SOC trial, we show the 30-day survival of patient with STEMI with cardiogenic was not improved, but there is a significant reduction of mortality after the 6 months of revascularization. And several meta-analyses showed a reduction in death or infarction with an early invasive approach after fibrinolytic therapy with either PCI or CABG. So what is the recommendation of PCI in the lead presenting STEMI? If patient presented after the 12 hours with ongoing ischemia, hemodynamic instability, then there is also recommended of primary PCI. And if also the patient presented with 12 to 48 hour, routine PCI strategy should be considered. But if after the 48 hours, if there is a total occlusion artery of infarct artery, there is a PCI is not recommended, but consider revascularization if symptom or objective evidence of viability or ischemia in respective territory. So there is some evidence of role of PCI in late presenting patient without ongoing ischemia. There is some trial like BRAVE 2 trial, they proven the benefit of PCI in reducing the infarct size in asymptomatic patient with STEMI. And there is a occluded artery trial which not recommended, with they told that PCI of totally occluded did not reduce the cardiovascular event. And so next is the when there is a total artery occlusion of more than 48 hours, if there is a evidence of viability, then we should consider the PCI. So for viability, they have there is a 3 terms which is usually used: myocardial stunning, which is the reversible state of regional contractile dysfunction that occurs after the transient ischemia without ensuing necrosis. Myocardial hibernation is a state of persistent left ventricular dysfunction that results from chronically reduced blood flow or repeated stunning without infarction or necrosis. And non-viable myocardium is myocardial perfusion is not restored, irreversible myocardial necrosis can occur. So there is a multiple modality to show the viability of the myocardium. Like for echo, if there is a wall thickness less than 6 mm, is highly suggestive of non-viable scar. In low dose dobutamine stress echo, there is a improved wall motion after stimulation with low dose dobutamine, which suggestive of viability. In SPECT, if there is a late distribution or distribution with second tracer injection suggests viability. In PET scan, mismatch between the flow and metabolism suggests a viability. In cardiac MRI, scar limited to subendocardium suggests the viability, while transmural or near transmural scar indicates non-viability. So we already discussed about the different pattern of viable myocardial viability. Like in stenting, there is a intermittent ischemia and reperfusion, and if there is a repeated stenting, there is hibernating myocardium. So both in the stent myocardium and hibernating myocardium, there is a contractile reserve and metabolism perfusion. So there is chances of recovery after the revascularization. But in the myocardial scar, it is there necrosis, there is a no contractile reserve, no metabolism and perfusion. So there is a minimum or no chance of recovery after the revascularization. And there is some recent trial, that revived Vicky's 2 trial, which suggests the PCI does not reduce all-cause mortality or heart failure hospitalization in patients with severe LV dysfunction and extensive coronary artery disease. But in this trial, they have not included the patient with limiting angina or recent ACS. So in condition with ACS, with patient totally occluded artery with suggestive of viable myocardium or any evidence of ischemia, there should be recommendation, there should be benefit of the PCI. Next is the revascularization non-infarct related coronary artery lesion STEMI. So patient without significant comorbidity with large non-infarct vessel, in selected hemodynamic stable patient with STEMI and multivessel disease after successful primary PCI of infarct vessel, stage PCI of significant non-infarct artery stenosis is recommended as class 1 indication. In some selected patient with complex multivessel non-infarct artery, after successful primary PCI, elective CABG is also a reasonable option. In low complex multivessel disease, PCI of a non-infarct artery stenosis at the time of primary PCI is mostly not recommended, is the class 2B recommended. And in patient with complicated by cardiogenic shock, routine PCI of non-infarct artery at the time of primary PCI is absolutely contraindicated or not recommended. So there is a multiple trial, in which major trial, which is a complete trial, which suggested of with patient with STEMI and multivessel disease undergoing primary PCI, complete revascularization was superior to culprit only revascularization. So they have in multiple trials, they have timing of the revascularization is multiple. Like in complete trial, they have revascularization at the time of the before discharge or after discharge. Next is the how to recommendation timing of the invasive strategy in patient with present with non-STMI. So if patient present with NSTMI with cardiogenic shock and refractory angina or hemodynamic instability, there is a class 1 indication for major invasive strategy. But patient with at high risk with Grace score of more than 140, there is an early invasive strategy within 24 hours, the class 2A recommendation. But in initially stabilized patients who are at intermediate or low risk for clinical events, invasive strategy with intent to perform revascularization before hospital discharge. So there is next is how to revascularize in patient with stable ischemic heart disease. There is a multiple trial which included the stable ischemic heart disease patient like Courage trial, Bari 2D, FAME2. They have all concluded there is no difference in the all-cause death and MI in patient with stable ischemic heart disease. There is no mortality benefit, but there is a quality of life is improved. So basically, according to this all this trial, revascularization in patient with stable ischemic heart disease can be classified to according to indication to improve symptom or indication to improve survival. If patient is refractory angina after the medical therapy, there is a class 1 indication for revascularization. But if there is a no angina, then there is an anatomic indication. Like if patient have left main disease with stable ischemic heart disease with high anatomic complexity and patient is suitable CABG, then CABG is recommended. If not suitable of CABG, then there is a hard time discussion for GDMT versus PCI. And if there is a significant left main disease with high anatomic complexity is not there, then also there is CABG versus PCI, both are recommended. But if there is a not left main disease, only multivessel CAD with anatomy suitable for both for CABG and PCI, so then we consider for there is a ejection fraction or LV dysfunction. If there is a LV dysfunction and suitable for CABG, then CABG recommended. If there is a not LV dysfunction, then can be GDMT or PCI. Revascularization based, so already we have discussed. So revascularization based on the improved mortality. So in which stable ischemic heart disease, if there is a left ventricular dysfunction and multivessel CAD with severe ejection fraction less than 35%, CABG is recommended. And for left main CAD with significant left main stenosis, then also CABG recommended for the improved mortality. But if there is a class 2A recommendation also, if there is a LV dysfunction with multivessel CAD with mild to moderate ejection fraction like 35 to 50%, then CABG is recommended. If there is a left main CAD in selected patient, PCI can provide equivalent revascularization to that possible CABG. So PCI is also a reasonable option for that patient. But if multivessel CAD with normal EF with significant stenosis with or without proximal LAD and anatomy suitable for CABG, then CABG may be reasonable to improve survival, but not class 2A. This is only 2B recommendation. But in patient with single or double vessel disease not involving the proximal LAD with normal EF, so there is a not recommendation for revascularization. In patient with stable ischemic heart disease, multivessel CAD appropriate for either CABG or PCI, revascularization is reasonable to lower the risk of cardiovascular events such as spontaneous MI, unplanned revascularization or death, cardiac death. But if there is a patient with refractory angina, in patient with refractory angina, despite medical therapy with significant coronary artery which is amenable to revascularization is recommended to improve the symptoms. Next is the PCI versus CABG in patient with a complex disease. Complex CAD means there is a severe tortuosity, heavy calcification, trifurcation, bifurcation or autoosteal stenosis. So in that patient, who require revascularization for significant left main CAD with high complex CAD, it is recommended to choose CABG over the PCI to improve survival. But in patient who require revascularization for multivessel CAD with complex or diffuse CAD like syntax score more than 33, it is reasonable to choose CABG over PCI to confer a survival advantage. So there is a CABG improves survival compared with PCI in patient with left main and complex CAD. If there is, what is the recommendation for the PCA patient with diabetes? Diabetes with multivessel CAD, appropriate candidate for CABG, then CABG with LIMA to LAD is class 1 recommendation. But if PCI can be useful in diabetes who have multivessel CAD and poor candidate for the surgery, and PCI may be considered to reduce the MACE event in diabetic with left main stenosis and low to intermediate complexity CAD. If patient with having previous CABG, then if there is a patent LIMA to LAD who need repeat revascularization, is PCI feasible, then go to the PCI, reasonable to choose PCI over CABG. But if there is a refractory angina or GDMT and there is a attributed to the LAD disease, and if there is a presence of LIMA is used to be conducive to the LAD, then it is reasonable to choose CABG over the PCI. And if there is a complex CAD, it may be reasonable to choose CABG over the PCI. So there is in this condition, there is a very heart team approach is important for those patients with a prior history of CABG requiring a revascularization. And this is also important consideration for patient undergoing CABG. So there is a calculation of the STS score is recommended to help stratify the patient risk for reoperation, prolonged ventilation, renal failure, death, stroke, and prolonged length of stay. So in patients who are being considered for CABG, calculation of STS risk score is recommended to help stratify patient risk, and the MELD score, gait speed, and MUST score may help in patients with cirrhosis, frailty, and malnutrition respectively. And some next is some revascularization guideline in special population and situation, like in patient with pregnant female. In pregnant patient with STEMI not caused by SCAD, it is reasonable to perform primary PCI as the preferred revascularization strategy. In pregnant patient present with NSTEMI, an invasive strategy is reasonable if medical therapy is ineffective for the management of life-threatening complication. And next is in older patient. As all inpatient, the treatment strategy of CAD should be based on an individual patient preferences, cognitive function, and life expectancy. In patient with CKD, undergoing contrast media injection for coronary angiography, measures should be taken to minimize the risk of contrast-induced AKI. And in patient with presented with STEMI with CKD, angiography and revascularization is recommended with adequate measure to reduce the risk of AKI. So there is some recommendation to reduce the chances of AKI, like assess the risk of contrast induced AKI before the procedure, adequate pre-procedure hydration, record the volume of contrast, pre-treat with high intensity statins, reduce as possible radial artery, delay CABG in stable patient after angiography beyond 24 hours when clinically feasible. Do not administer N-acetylcysteine to prevent contrast-induced AKI. Do not give prophylactic renal replacement therapy. Next, like in patient with presented with SCAD, so who have hemodynamic instability or ongoing ischemia despite conservative therapy, revascularization may be considered if feasible. It is only to be recommended, but if there is a routine revascularization, SCAD should not be performed. Next, the patient with a cardiac allograft, vasculopathy and a severe proximal discrete coronary lesion, revascularization with PCI is reasonable. Next is a patient presented with ventricular arrhythmia. In patient with ventricular fibrillation and polymorphic VT, cardiac arrest, revascularization significant CAD is recommended. But if patient with CAD with suspected scar-mediated monomorphic VT, revascularization is not recommended. And next, before non-cardiac surgery, in patient with non-left main or non-complex CAD who are undergoing non-cardiac surgery, routine coronary revascularization is not recommended to reduce the perioperative cardiovascular events. And they also recommended some general procedure issue before the PCI, like vascular access of PCI. They recommended the most use of radial approach to decrease the 30-day rate of death, MI, major bleeding and vascular complication. They recommend DES should be used in preference of BMS class 1 indication. And for IVAS and OCT, there is a class 2A indication in patient with undergoing left main and complex coronary artery stenting. How to determine the mechanism of stent failure, for lesion preparation, stent sizing expansion and evaluate the complication. So there are multiple studies which compare with angiography guided versus imaging guided. So there is a significant reduction of MACE, target vessel revascularization and target vessel failure with imaging guided PCI. Next, for thrombectomy in STEMI, routine aspiration thrombectomy before primary PCI is not useful. It is only useful for selective use in patient with high thrombus burden. And for the calcified lesion, in fibrotic heavily calcified lesion, plaque modification with rotational atherectomy improve the procedural success. For saphenous vein graft disease, in PCI or saphenous vein graft, use of embolic protection device can decrease the risk of distal embolization. And PCI of the native coronary artery is preferred of the SVG PCI if feasible, because they increase the perioperative MI, no reflow stent thrombosis in the SVG intervention. PCI of the chronic occluded SVG should not be performed. For ISR, for PCI of ISR, a DES should be used to improve the outcomes. CABG can be useful over repeat PCI to reduce the recurrent events if in symptomatic diffuse ISR. And for some hemodynamic support, elective placement of hemodynamic support system device such as Impella IPP may be reasonable to adjunct to PCI select high risk patients. And for CTO, there is only class 2B recommendation in patient with suitable anatomy and refractive angina despite medical therapy and treatment of non-CTO lesion. So the benefit of CTO PCI to improve the symptom only, there is a symptom improvement. Like for CTO, there is only multiple trials that have 80% procedural success, 1.3% 30-day mortality, and there is a two major trials, Euro CTO trial and Decision CTO. In Euro CTO, there is a significant reduction in angina frequency and improved quality of life. But in Decision CTO, there is no difference in symptom and clinical outcomes. And they recommended for some antiplatelet oral P2Y2 inhibitor in patient undergoing PCI. So there is a class 1 indication of aspirin and clopidogrel in patient present undergoing PCI in STEMI and stable ischemic heart disease. And they also recommended ticagrelor and prasugrel class 2A indication. And prasugrel should not be given having prior history of stroke or TIA. And patient with ACS undergoing PCI with large thrombus burden, no reflow, slow flow, intravenous GP2 inhibitor agent are reasonable to improve the procedural success. So benefit of GP2 inhibitor has decreased with short revascularization times and potent DAPT. And for recommendation of anticoagulation patient undergoing PCI, so administrative of IV heparin useful to reduce ischemic events, and in patient with heparin induced thrombocytopenia undergoing PCI, bivalirudin ergotamine should be used. And important is in patient on therapeutic subcutaneous enoxaparin in whom the last dose was administered within 12 hours PCI, unfractionated heparin should not be used for PCI and may increase the chances of bleeding. So antithrombotic therapy is a mainstay of treatment in patient undergoing PCI. And use of DAPT, if there is undergoing PCI in stable ischemic heart disease, use of DAPT is recommended for class 1 indication for 6 months. If there is a high risk of bleeding or overt bleeding, then discontinue P2 vital inhibitor after 3 months may be reasonable, and discontinue aspirin after 1 to 3 months with continue P2 vital monotherapy. And after the 6 months, if there is no high risk bleeding or significant overt bleeding, DAPT can be reasonable class 2B after more than 6 months. But in patient present post PCA after the ACS, 12-month DAPT is recommended. If there is any chances of discontinuation of aspirin for after 1 to 3 months with continued P2 vital monotherapy. If there is a high risk of bleeding, overt bleeding, then discontinuation of P2 vital inhibitor after the 6 months may be reasonable. And if there is a no high risk of bleeding or significant overt bleeding, more than DAPT can be continued for more than 1 year. This is a class 2B indication. Antiplatelet therapy and anticoagulation after PCI in patient with atrial fibrillation. So there is a recommendation of triple therapy of DAPT plus anticoagulation in patient with AF. So recommend discontinue aspirin after the 1 to 4 months while maintaining P2 vital inhibitor in addition to Novec. And if patient is on DAPT with P2 vital inhibitor monotherapy, then it is reasonable to choose a NOAC anticoagulation over the warfarin. So for take home message for this recent guidelines, treatment decisions should be patient centered, incorporate patient preferences and goals, and include shared decision making. For patient with significant left main disease, surgical revascularization is indicated to improve survival relative to that likely to be achieved with medical therapy. Percutaneous revascularization is a reasonable option to improve survival compared with medical therapy in selected patients with low to medium anatomic complexity of coronary artery disease and left main disease that is equally suitable for surgical or PCI. Revascularization decisions for stable ischemic heart disease are based on consideration of disease complexity, technical feasibility of treatment, and heart team discussion. A short duration of dual antiplatelet therapy after PCI is in patient with stable ischemic heart disease is reasonable to reduce the risk of bleeding events. Stage PCI while in hospital or after discharge of a significant stenosed non-culprit artery in patient presented with a STEMI. Revascularization is in patient with diabetes and multivessel coronary artery disease are optimized by the use of a heart team approach. Patients with diabetes who have triple vessel disease should undergo surgical revascularization per PCI may be considered if they are poor candidate for surgery. The usefulness of sentence score calculation in treatment decision is less clear because of the inter-observation variability in its calculation and its absence of clinical variables. Thank you.